All right, so I'm going to stop here and welcome our girl, our very own Dr. Monica Parker, who will stand before you as our Director of Outreach, Recruitment, and Engagement, and our Minority Engagement Core Director. I always love when Cornelia says that she's a squeaky wheel because she gets stuff done and you all matter a lot to her. So let's give her a round of applause as she comes up and sets the stage for this 3-year anniversary, Dr. Parker.
Okay, thank you again. As Crystal said, I want to welcome you to our Minority Men's Health Discussion Group, 3 years in the making. And every time we see you and we see more than 100 people in the room, we're really, really, really happy. So to the new people, raise your hands again. We're the new ones. Okay, all right. For all the new ones and somebody who brought them, I want to make sure that you filled out a form to say that you brought them so that we know who you are. So if you haven't done that, see one of the ladies on the side of the room so that we can get that done. We want to reward you for your efforts. We reward you for your efforts by feeding you, first of all. Us make a difference. If you looked at Good Morning America this morning, they were talking about the high incidence of cancer in communities of color, where you're going to help us make a difference in Alzheimer's related research. You're already known for it around the country, but if we keep up efforts like this organically, not just here in Atlanta, but other places, we're going to do that. And it can start here with us. And so we're going to get your participation a little bit later in those sorts of things. I do want to acknowledge some of the gentlemen who have been with us since the very beginning. We have a group of men who help continue to guide our program. Some of them are here, not all of them are here. Dr. Clinton Dye is a licensed clinical social worker who's been with us since the very beginning. His wife was one of our patients, or one of my patients, and one of the neurology patients. Dr. Cornelius Flowers, who is a former Emory, he's still a cardiologist, he's just no longer in active practice. Mr. David Dorbin, the spouse of our departed Cornelia Dorbin. Well, she's gone. She is not forgotten, but the work lives on. Okay, how about that? Mr. Karen Graves, and he deserves a real special shout out because he's really the one who had the idea, and the rest of us came along and built it up. So thank you, Mr. Karen Graves. I gotta say this about Mr. Graves. He was learning about brain health, and he made me ask me to speak to a group of golfers called the Atlanta Duffers. How many Duffers are in the room? Okay. And shortly after that, Mr. Graves became the poster child for, well, why aren't more people doing this? I'm like, well, can you help us with that? And so from those discussions, we've got this. And thank you, Mr. Graves. Thank you to the Duffers. And thank you to all of the gentlemen who help us. Maybe we don't do a program at your church, but we will come if you ask us and try to organize what it is you want. To the men who belong to the different church and faith connections and fraternities, and you know who you are, but a couple of you I have to single out because you do a whole lot of special stuff for us, and one of those is Mr. Greg Bailey. Where is he? Thank you. He hosted us for a men's program at his church, and even if we haven't done a program at his church, he's brought busloads of people from his congregation and in his area in Gwinnett County to our brain health forum. So even if you can't get somebody in here on the second Thursday of every month, and we're not going to change that calendar, you guys are programmed, right? Okay, second Thursday every month, bring somebody. And if you're coming and you haven't participated in research yet, we would really like you to. We really need all of your participation. If there's something that you don't want to do, you don't have to do it. But the simplest way that you can participate in research is filling out a questionnaire. Emory Healthy Aging, just a questionnaire. No blood, no MRI, no lumbar puncture, just a questionnaire. So let me get to my part, which has to do with a little bit of update on where we are. I've shown you this slide before, but for those people who are new, who think this stuff just happens and we just throw a good party, well, in the National Outreach Recruitment and Engagement Corps, we've decided that we need to make sure that everybody understands that recruitment is a science. And yes, feeding and entertaining you is a part of that science, but it's part of what it requires to get you in the room. So to get you in this room, it's taken me 20 years, okay? Actually, maybe a little less than that, 22 years. This is the timeline. So in order to do these kinds of things, it takes money. The National Institutes of Aging, National Institutes of Health does not pay for your food. Philanthropic donors do. Okay, and we're gonna help you get to the point where you can earn your keep, because I know a lot of people say, well, you don't need to give me a free meal, I can pay for it myself. I know you can. I can too. All right, but in order to get a broader outreach, we have to get more people to kind of buy into it. So back in 2008, 2010, Dr. Lott asked me if I really wanted to do something about engaging people that look like me in research. We applied to NIH, we got a minority supplement award for me to learn how to better engage people, but I knew what was needed, really walking around, talking to everybody, getting the door slammed in my face. Well, I'm not ready for that. I don't know that my pastor's gonna go along with that. Let me talk to the president and see. So I said, okay, all right, I did that for 2 years. I tried to take a statistics course so I could be a little bit more proficient with numbers. That didn't work. But I know what does work, and that is a personal connection. So as a clinician, I have a lot of connections with several people who are my patients who've helped me with this. Many of them belong to the social groups that I belong to, but the first people that I really recruited and recruited heavily were my family members, my sorority members, my church members, and my patients that I strong-armed really, really well. And then you can see how we've done a number of different things and who's helped us fund this engagement. But one of the pivotal things, and this is important nationally, is our Alzheimer's Disease Research Center committed to making sure that people who were enrolled in their research projects were at least it was going to be at least half African American, to be more accurately reflective of the population here in Metro Atlanta. You can go through and read the rest of it. Everybody who comes in front of you came because we got a little bit more money to get a little bit more people to help us with this effort. The Minority Men's Health Discussion Group was launched in 2021, in part financed by a grant we got from the Biogen pharmaceutical company. All right, these people, now why are you looking at this slide? You're looking at this slide because these are some VIPs. The first one is Bishop John Hurst Adams, an Episcopal bishop in the AME Church. He said, Monica, if you really want to get people of color involved in this, you need to work with the formal structures of organizations that operate within our community. So everything that falls from this isn't coming from a researcher, it's coming from somebody who understands how to reach people. So Bishop Adams is deceased, but through his efforts, he secured a lot of participation for us through the AME Church here in Georgia and nationally. This is a young lady from, these two young ladies are from First Congregational Church in Atlanta, the Guild, I'm gonna get Servette's Guild. Okay, we had some of our first public programs at First Congregational Church in Atlanta. These ladies, this one right here has been involved with our research for more than 12 years, and she has been really instrumental in facilitating a lot of community programs. Both of these ladies are retired school teachers. So school teachers are near and dear to me. Bishop Hurst, John Hurst Adams was one of my mother's college classmates. I didn't know it at the time, but when she walked into her room, she called him by his nickname, and I'm like, you know him? And I'm like, you know her? And it's just like, well, yeah. And we had a neat discussion after that, just let you know how closely many of us are, closely connected we are. This is our program posters from several of our minority men's health discussion programs, and you can see what those titles are. If you've been to more than a few, if you started with us in 2021, these are not new to you. What's formatted, how we do things may be a little bit different. Okay. Okay. These are the numbers. These are the things that are important. These are the things that you wanted some information about. To date, since July of 2022 through November of 2024, we've reached greater than 1,600 unique individuals. That means numbers that you see are not people who are repeating themselves. More than 600 of you have expressed an interest in research, and the blue stripes are the number of minority men's programs we've had, and the numbers on top are the number in the audience. The orange line are the number of people who filled out the research interest forms that got us to the 600. And then the yellow numbers are the ones who actually consented, actually came in, signed a consent form, gave us a biospecimen, whether it was your blood, your cerebral spinal fluid, gave us your opinion, or took a special MRI or X-ray study and participated in not just one study, but more than one. These are the breakdowns of the people who have come to the different studies. These are 3 different studies that we have recruited for. One is called Emory, which is the one that's most closely aligned with our longitudinal data set around the country. The other is the Emory Healthy Brain Study, which is piloted by or organized by Dr. Law. I'm one of his co-investigators. And then the PAN study, he's the lead investigator, project coordinator for it. I know you can't see all of this, but the thing that's important here is that let's just take this first column here, memory referrals. We referred from this program 74 African American men. Of those 74 men, 37 have actually signed a consent and participated in research. 242 went to the Emory Healthy Brain. It's the 83 that's important. Okay, these are the ones that have signed up for research. These are the numbers that we're reporting nationally and that we base a lot of the the publications that are coming in that we have published that talk about the differences that Dr. Law is going to go into a little bit later. So these are more studies. Pay attention. 14 went to SCAN. That's Dr. Trammell's study on blood pressure medicines. 3 have consented. Blue is the number here. So from the period 2016 to 2021, we had about 211 African American men, I don't know what happened here, who actually started participating in our research. From the period of 2022 to 2024, we had 212. So half the time, same number. So look at the numbers. These are the number of people who are actually consent. Oh, I started to cuss.
Crystal, stay up there.
Stay right here. Okay, but I want you to look at these numbers. You've gone from 11 in a year. You've gone from 11 in a year to 400, don't move. 478. Look at those numbers. Okay, these are men that are actually enrolled in clinical research studies. Not all the same ones, but clinical research studies. Okay, you all move it. Okay, with that, I'm going to bring you your real dessert for the afternoon, or Dr. Locke. Want one afterwards, but there are more old heads in here and seniors. I'll give you your own one-on-one 10 minutes at the end.
Okay.
Not up front, in the corner.
I tried to send her to technology school. So glad to see some red Santa caps. Here's mine. This thing only comes out once or twice a year. I haven't felt terribly celebratory since a Tuesday in November. But I thought I'd break it out for you guys. I didn't realize when Dr. Parker asked me to do this event that this was going to be the 3rd year anniversary. I was like, wait a minute, I thought we had our first event in that parking lot after springtime. And we did, but that was our first in-person event. But when we first started this, it was in December of 2021, when another wave of COVID hit. And so we had to kind of delay things a little bit. But it's amazing to see where we've come in those 3 years. It's just unbelievable. And she won't admit this, but for years while Dr. Parker and I were working together, we were having so much success engaging the community, but it was all women. And I said, Monica, we got to do something to get more men involved. And she said, yeah, I know. And then finally, the right connections got made with Mr. Graves and with others. And now look at us. This is amazing. And I can tell you, there is not another center in the country that has had this kind of success with Black men. I'm going to show you some numbers. So how many of you were at the most recent Brain Health Forum at the Carter Center? Okay, so I knew a bunch of you were going to be there, so I've recycled a couple of slides from there. But I like this that I created for that event because there have been some amazing things that have happened. I don't think there was a direct relationship between you all getting involved in these advances happening, but there have been amazing advances in the last couple of years since this event has been running. And so I want to talk about a little bit of that because there's some really optimistic things that have happened. And then I also want to talk about some major challenges that remain and some of the things that we're learning with your help as part of our research activities. So many of you know there have been 2 drugs now. After over 20 years of nothing happening, there have been 2 new drugs that have been approved for Alzheimer's disease treatment. These are much more effective than the older drugs that we've had. And these have happened, the approvals have happened in 2023 and 2024. And what these drugs do, they do a very similar thing. These and other drugs that are in development do some very similar things. These are pictures of a brain that's been injected with a dye to show the presence of Alzheimer's disease. So we can see Alzheimer's disease. This is the Alzheimer's amyloid disease, amyloid pathology. And that dark stain on the right-hand side image is from somebody who has Alzheimer's disease. And what these drugs do is they go in and they remove that amyloid. So what you're looking at on the left-hand side here is a patient of mine who's been treated with these anti-amyloid drugs for about 3 years, and all of that amyloid is gone. It's gone. So Alzheimer's has amyloid and tau, and both of those are universally present, and we can make that amyloid disappear out of the brain. Okay. More importantly, though, and these are the data, and don't worry about the details of this. These are the data from large clinical trials of these 2 drugs that have been approved. They do the same thing. Compared to people who were not treated with active drug, they got something called a placebo. Compared to people who weren't treated with active drug, people who were treated with the active drugs over the course of 18 months didn't progress as much. So when we talk about Alzheimer's disease, or dementia in general, from dementia illnesses, the thing that scares the hell out of people is not what you look like when you're just having a couple of memory lapses. The thing that scares the pants off of people is what you look like if you're in a nursing home and don't recognize your loved ones and can't do anything for yourself. And that's the end product of a long clinical course of many years of deterioration. And so what these drugs do, when you compare those 2 groups over the 18 months of the trial period, the people who were treated with drugs declined 25 to 30% less than people who were not treated with drugs. Well, what the heck does that mean? 25 to 30%? You didn't stop it, you didn't reverse it, you didn't fix it. What does that mean? What that means is, remember, this is just during that 18-month period when we're comparing people who got real drug versus those who got placebo, and there was a difference. But if you project that out, Alzheimer's and dementing illness is not an 18-month disease. It's a 10, 12, 20-year disease. So if you project that out, what it means is it slows down the progression of disease, and the hope is that what that means is that people will die, get run over by a bus or whatever's going to take you out, you get taken out before you get to that scary stage of disease. And that's the promise of these new drugs. And that's a major advance. It's not a last step, but it's a really, really important first step. Because, like I said, what you want to avoid is you want to avoid that terrible late stage of disease. For all dementing illnesses, whether we're talking about Alzheimer's disease or anything else, in very early stages, there's very mild symptoms. People are functioning normally. They're running businesses. They're practicing law. They're doing all kinds of stuff with minimal trouble. The problem is over time it gets worse. And so these disease-modifying treatments give you a chance of never getting to that horrible late stage of disease. But we ain't done, because what we need to do is we need to advance that further so that we're treating people even earlier, so that we can delay or prevent disease altogether, whether it's Alzheimer's or something else. And that's where we're headed. And by the time your children and grandchildren get into an age bracket where they might be at greater risk, I promise you, we're going to have a lot of advances, and we're going to be doing more monitoring and prevention. So that's the good news, right? And that is really good news. But there are still challenges. There's still a lot of challenges that remain. And I'm going to talk about, specifically, I'm going to focus on those challenges that remain that are particularly pertinent to the people in this room, people of color, men, women, doesn't matter. People who are not white, non-Hispanic white people. Because most of what we know about these diseases comes from research and studies in white folks. And yet, when you look at the CDC and other data from the Alzheimer's Association and other groups, people of color, underrepresented in research individuals, are at higher risk of developing dementia. And in fact, this is a CDC slide that estimates that Alzheimer's disease is going to be tripling by 2060. It's 2060, right? Yeah, 2060. And then among Hispanics and African Americans, over age 65, the estimate is that non-Hispanic whites, overall, there's about a 10% rate of Alzheimer's disease. And that rate in African Americans is 40% higher from the CDC estimates. And in other estimates, it's even higher than that. Okay, so keep that in mind. I also want you to notice that this is specifically talking about Alzheimer's disease. All right, and I'm going to bring that up towards the end as well. But it is absolutely true that people of color at higher risk of developing dementia in late life than white folks are. Okay. And these are some data to support that. I didn't select this slide because Asians were at the lowest risk. That's kind of good news for me, I guess. There's really very strong data that, like in this study from Kaiser in California from a number of years ago, very good data, longitudinal data. And African Americans in this study were 73% more likely to develop dementia after age 65 than Asians were, okay, Asian Americans. And then this is another study that was done in New York City in the Washington Heights neighborhood. And here it's broken up by age. But if you look at the people between 75 to 85 and over age 85, the rate of dementia among Black folks was twice as high as what it was among white folks. Okay, so these data are very consistent. There's no question the rates of dementia in late life is higher among Blacks than among whites. And I told you about those two really cool studies, right, that showed how much impact these new drugs can have on slowing down the progression of disease. Well, let's get into the weeds of these studies a little bit, okay? So in one of those studies, in the top there, you see there were 875 people who got placebo, and 859 who got active treatment. Break that down a little bit, look at that. How many Black folks were in this study? 24 got placebo and 20 got treatment out of 1,700 total participants, okay? And not only that, because those numbers are so small, that line, that dot and that line reflects whether patients in that subgroup benefited from these drugs. Maybe, but we don't know, because that long branch there that extends out past that dotted line, that's what we call a confidence interval. And that confidence interval, if it's crossing that dotted line, it tells us we can't say for sure whether these folks benefited from these treatments. And because there's so few Black folks in the study, we have no idea. Okay. What about the other drug? Well, same damn story. So out of a total of about 1,600 or 1,600 people, there were 19 African Americans who got placebo and 19 who got active treatment and 21 who got placebo. So you really can't say whether these drugs, we think they are, we're certainly treating our Black patients with these drugs, but we don't really know because there were so few African Americans involved in these studies. And this is a problem that's current, and it's a future problem too. So this is a schematic of what we think happens with Alzheimer's disease and other degenerative brain diseases. This is specific for Alzheimer's disease. And that MCI, mild cognitive impairment, that's circled in the bottom there, that's the first time that you can be recognized and diagnosed clinically as having symptoms of memory loss and decline. So this is when your daughter, because your sons are useless, but daughters call you all the damn time, and they say, "Daddy, you don't remember we talked about that?" This is when we can first diagnose memory decline that ain't normal. Okay, but we think that the disease, the pathology is building up 15 to 20 years before people first develop symptoms, okay? So I showed you that graphic of disease-modifying therapies to slow things down so people get a chance to die from whatever they're gonna die of before they get really terrible. What we really need to do is attack this disease like any chronic disease. You don't wanna wait until somebody's had a huge heart attack to treat the heart disease or the cholesterol. You wanna prevent that heart disease. And we want to do the same thing with Alzheimer's disease. And this is some data from us. This is our data from participants in our research. And what I'm plotting here is how many people, what proportion of our research volunteers who are cognitively normal, no memory problems, no MCI, no dementia, how many of them, what proportion of them have evidence of silent pathology? And in young people, it's very low. Under age 55, it's under 5%. But by the time you get to over age 70, it's over 20%, okay, that have silent pathology and silent disease. Well, how do we know that? Actually, I'll come back to that. And the reason that that's so important is because we are now using these same strategies that we use to demonstrate that we can slow down progression of Alzheimer's disease in patients, in people, not patients, in people who have evidence of pathology, but no symptoms. And this is a study that's happening right now that's using one of those approved drugs in people before they have symptoms. So people between the ages of 65 and 80 who have evidence of Alzheimer's pathology on their brain scans or on spinal fluid, and then getting treated to see if we can delay or prevent disease from happening. We expect results from that study in 2019, but I can tell you, and Dr. Parker will tell you, actually, she's been annoyed about this. I'm like, Monica, what's wrong with you? She was annoyed because she didn't qualify for the study. And I said, Monica, that means you don't have any pathology. It's like, I feel like I've been rejected. I'm like, Monica! However, it is absolutely true that the screen fail rate in these studies has been very high for African Americans. I tried to get the total number that have been enrolled currently in this study, And I wasn't able to pull that number for you guys, but I can tell you it's a pretty small number. And why is that? Well, partly it's because we're not reaching communities of color for our research. Partly it's because communities of color understandably have less confidence and trust in the system, but there may be other reasons for that. One of those reasons is how we know whether somebody has presence of silent pathology or not. So this picture on the left is it's just a nice picture. All that white that's surrounding the brain and the base of the brain, that's all spinal fluid. And we can collect that spinal fluid safely below the end of the spinal cord in the lower back. And we can measure proteins that are associated with those Alzheimer's pathologies, the amyloid and tau. And by measuring those levels, we can make a very strong, very confident prediction of whether we would see evidence of pathology or not. Okay, so people who don't have Alzheimer's pathology have higher levels of something called amyloid beta in the spinal fluid and lower levels of the tau protein. Don't worry about why that is. There's kind of hand-waving explanations for that. But people who have Alzheimer's disease in their brains, even if they don't have any symptoms, have lower levels of the amyloid and higher levels of tau. Okay? So by looking at that pattern, we can say this person does or this person does not have Alzheimer's pathology in their brain. Well, how do we know that? Well, we know that from data that was generated in something called the Alzheimer's Disease Neuroimaging Initiative, and another large study. There are some other studies, but these are two of the big ones, something called the Swedish Biofinder study. Well, in Sweden, I didn't take a demographic profile of the average Swedish population, but I'm kind of guessing Skåne University Hospital and Ängelholm Hospital don't have a lot of people of color. Okay? In the US study, in ADNI, this has been going on now since 2003, I think, and it's gone through multiple iterations. ADNI 4 is going now. And in those studies, 92% of participants are white, 4% were African American. So just like with the clinical trials, the data doesn't exist. So we presume that these results that are extrapolated from white populations, European ancestry populations, are going to apply to you and me and everybody else who may or may not be a European ancestry. So we've made some great advances. We can detect silent Alzheimer's pathology. We know we can do that, and we can do that up to 20 years before people get sick. We can't yet predict who's actually going to get in trouble. So I'm not going to talk about this, but when we look at brains of people who donate their brains that were cognitively normal, didn't have any problems, about a third of them have abundant evidence of Alzheimer's changes, but they never got sick. So that's one of our challenges. We need to figure out who's actually going to get sick. Because if you're never going to get sick, who cares if you got amyloid and tau in your brain? Right? It ain't bothering me. Leave it alone. We also don't understand Alzheimer's and dementia in minority populations. And that's where what Dr. Parker was showing you earlier, where we have really focused attention. And it really was, Dr. Parker has done so much in advancing this. And Bishop Adams, he's a great man. And all the folks who helped us sort of build this, going back over 15 years now, really have done amazing work. But that's what we've been focusing on. And I'm highlighting the Alzheimer's Disease Research Center and the Emory Healthy Brain Study, which are two of the larger vehicles that we're using to try and understand this. And I didn't do like a backtracking all the way to 2000 and whatever Dr. Parker went back to. I said, all right, we've been doing this for 3 years. Let's see what's happened. Have we had an impact? Have you guys had an impact on the participation rates over the last 3 years? And I compared it with the 3 years preceding. So from 2019 to 2021, we were already doing some pretty significant engagement, and we weren't bad. We had 22% Black participation in the Alzheimer's Center and the Healthy Brain Study. But in the 3 years since we've been doing this, that proportion in those two cohorts, those two large cohorts, is over 34% now. So a huge improvement. And then going back to when I was bitching to Monica about years ago, it's like, we got all these Black women participating. Where are all the Black men? Look at this. This is 2019 to 2021. This is something that has been directly impacted by you all in this room. Back in 2019 to 2021, 4% of our participants were Black men. There were 17% were Black women. That was pretty good, but 4% were Black men. You always notice there are more women than men in these studies. That's just because women are just better than us. That just goes without saying. It doesn't matter you're Black, white, Asian, it doesn't matter. But this was the biggest discrepancy, 29% and 4%. That's like huge. Look what's happened since this program started. Parker and I saw Dr. Trammell in here somewhere, but we've been threatening to write up our experience in a paper. And one of the funny things that's turning out is that even though people think that Black men are the hardest people to engage, all we have to do is get in front of you. And have you say, well, that guy doesn't look too much of a scoundrel. Maybe I'll trust him a little bit. And that's all we needed to do. And the number of touches that we had to have with Black women, they want us to wine them, dine them, talk to them 17 times before they sign up. Black men come and say, yeah, you guys look all right. 1 visit, 2 visits, sign me up. Stick a needle in my back. And that's been the experience. And we need to report that just so you don't get such a bad rap anymore. And then look at this, the spinal fluid collection. This is really important because we're doing a lot of research with the spinal fluid, and the same thing holds here. And so what does this allow us to do? We published some work. Remember, the CDC says Alzheimer's disease is 40% more likely in people over 65 who are Black versus people who are not Hispanic white. Alzheimer's disease specifically. So we started looking at how frequent we see Alzheimer's disease. So when you talk about diagnosing people clinically, it gets tricky, right? There's all kinds of biases that we know about in clinical medicine. When people interact with patients, there's a difference depending on whether their patient is like them or different from them. There are cultural differences and different ways that people perceive things, and some of those are terrible things. Some really awful racist kinds of things. But even without the elements of racial bias, there are failures in how we diagnose people. We're just not that good. But when I'm talking about people who are healthy, I'm not going to be impacted so much by bias, right? So if I say you're healthy and you're Black or white or Asian or Native, doesn't matter. You're healthy. I don't have to diagnose anything, right? So one of the things that we did was we said, all right, now we've got like hundreds of spinal fluid samples from African-American donors. And we're just going to look at the healthy people, whether they're Black or white. And if Alzheimer's disease is 40 to 80% more common in Blacks than in whites, among healthy older Black people, there ought to be a much higher rate of Alzheimer's silent pathology than among white people, right? If that's absolutely true. Well, so we used the cutoff values from the spinal fluid from ADNI, that's the graph on the left, and said, well, what proportion of all of our white participants who are normal have evidence of silent pathology? And it's consistent with national other studies that have estimated with the population age distribution, it'd be about 12%. That's about what we saw. But among our healthy Black participants, it's only 6.5%. And I said, well, that can't be right. Alzheimer's is more common in Black people than white people. And so we kept beating up that data to try and make it give me the right answer, and it wouldn't give me the damn right answer. And so we did some modeling and did other fancy statistical analyses. And no matter what we did, the rates of silent Alzheimer's disease in our Black volunteers who donated spinal fluid is lower than among healthy white people. So what the heck's going on there? Because there's no question, age-related dementia is more common in Black folks than in white folks. There's no question about that. So what the heck's going on? So when we talk about dementia in late life, we're not just talking about Alzheimer's disease. There's vascular disease, stroke-related changes that can cause cognitive decline in dementia. There's something called Lewy body disease. There's frontotemporal dementia. And they're all associated with different pathology, right? So these things all can cause progressive deterioration and dementia. They can all lead to that awful, terrible late stage of dementia. But there are different causes for that. And this is what we think is the distribution. We think 65% of dementia in late life is caused primarily by Alzheimer's disease, and then different proportions of these other conditions. And so that's our estimate. So how do we know that? Well, we know that based on a whole bunch of studies, and guess what? A whole bunch of studies just in Black people. No, no. Whole bunch of studies in people primarily of European ancestry. There have been more studies that have been done in Asian populations, very few on the African continent, and the data among US populations is predominantly among white people. So these estimates of what causes dementia in late life, again, just like the spinal fluid data, just like the clinical trial data, is based predominantly on studies that were done in non-Hispanic white people. So what you guys are doing in this room, participating, encouraging others to participate, inviting us to your churches and your organizations to come and talk to you so that we can build our trust and understanding with our communities of color is what's absolutely necessary for us to overcome these disparities in our knowledge, so that when we say these treatments to delay or slow or prevent dementia is going to be just as applicable, and we have just as much knowledge about the effectiveness and safety of these treatments in all populations, not just in select populations. So thank you so much for just participating. We just love having you guys. So grateful. And
we're going to move to our question and answer phase. Now, the way we're going to do this is we have three people holding the mics. It's going to be this section, this section, this section, and start all over again. Mr. Chris, who else has the mic? Come on. So at this part, our new co-director of our Alzheimer's Disease Research Center's Outreach Recruitment Engagement Corps is Dr. Antoine Trammell. Dr. Trammell is duly appointed to the Department of Internal Medicine and the Department of Neurology. He is the director of the Georgia MemoryNet's Atlanta site. This is the site where we refer people who don't come here for Alzheimer's evaluation in Atlanta. Yes, it's Nick Brady, and all poverty is Nick Brady. It just happens to be the site. We're going to move it to a better off-campus kind of site moving forward. But if you don't have a neurologist, but you have a primary care doctor and you need to have a dementia evaluation, Georgia legislature, with your tax dollars, has funded the development of seven different keeping one on here, memory assessment centers throughout the state of Georgia. The way you get there is through your primary care doctor's referral. So we're going to talk about that. I'm happy to say that the Memory Assessment Center development grew out of community conversations here at Emory University, Department of Neurology, Department of Geriatrics, where I was at the time, psychiatry, and all the areas of administration on aging, anybody giving services to older adults in Georgia. That started 2013, 2012? 2017. And the Georgia MemoryNet is ongoing. The legislature has given us more money, but Dr. Law is the director, if you will, of the Georgia MemoryNet, but that was born here at Emory University, and it serves the entire state. Dr. Trammell, our new ORCOR director, who's going to be moderating this session for you this afternoon, is a big part of it. I just feed stuff in here. Okay, questions? Okay, raise your hand. Christopher, we're going to go Christopher and this one, and then back and forth. Okay.
I'd like to know, with the new drugs, what are the side effects?
So I didn't talk about the side effects, and they're significant, and they can involve swelling and bleeding. When we talk about brain bleeds, people usually kind of sit up and take notice. The frequency is not rare. It's between 25 and 35% that you may have these areas of swelling. They're really microbleeds. They're not big bleeds. They're little tiny spots of blood. And most of the time it's silent, but they can be symptomatic. And in each of those clinical trials that I showed you, 3 people died in each of those trials. And so we take that very seriously. And so we do a lot of safety MRI scans to monitor for that. Most of the time, 85 to 90% of the time, even if there is some swelling or microbleeds, they have no symptoms. The other thing to keep in mind with these drugs is not like picking up a prescription at the CVS. It's more like chemotherapy. It's IV infusion drugs that are given every 2 weeks or every 4 weeks for 12 to 18 months. So very different from traditional medications. And they have significant potential risks, and that's why not having data in diverse populations is a real concern, because we just don't know whether the complication rates are higher in certain populations or not.
Dr. Trump?
Question I had was, is the reason why African Americans' percentage of Alzheimer's is so much higher, is it because of hereditary? Is it lifestyle, or just a combination of both?
So the short answer is we're not sure. But remember, we're not just talking about Alzheimer's disease, right? So when Dr. Parker does Dementia 101, one of the things that we try to highlight is what's the difference between Alzheimer's and dementia. And so when we talk about dementia, it's any disease that can cause cognitive and functional decline. When we talk about Alzheimer's disease, we're specifically talking about people who have that Alzheimer's amyloid and tau in the brain, right? And so really the question is, why is dementia in late life more common among African Americans? And so part of that is maybe genetics, but I'm not sure that I believe that. There's when we look at specific genetic contributions, we do that in kind of a messy way, but there have been some studies looking at genetic influences in a specific population in Africa. There's a Yoruban population that's been studied for Alzheimer's related genetics and Alzheimer's risk. And some of the very small studies that have been done suggest that maybe it's not so common in African populations as in African American populations. So that suggests that maybe the genetics isn't such a huge driver. So what is? I think that what we're going to find, and I think what we're going to learn, is that as opposed to these neurodegenerative conditions that have been largely defined in European ancestry populations, there can be other contributors, specifically vascular contributors. So among African Americans in the US, African American, that's a little redundant, ain't it? As opposed to African Americans in Chile, the rates of hypertension and diabetes and obesity and other cardiovascular risk factors is substantially higher. So I think that's going to be a major contributor. The other, I think, is stress. So I was telling Dr. Parker that I feel much safer in this room than I do in other rooms with other people sometimes, and I think I'm still getting over November. But you had to deal with that in a very different way than I've had to deal with that. So the level of stress that Black folks encounter on a regular basis, I think, is a major driver to the higher rates of hypertension, separate from other health considerations. And so I think it's really these comorbid conditions and societal conditions. There's something called social determinants of health, which is a really important area of research, looking at all of your exposures through your entire lifetime, because that all adds up. So your risk of being sick or your likelihood of being healthy when you're 70 is tremendously impacted by where you grew up when you were a kid and when you were a young adult and what you were exposed to, the air pollution, the access to healthy foods, the access to education, the access to healthcare, the exposures to stress and anxiety. All of those things over 50, 60, 70 years is going to have a major contribution in health and disease in late life. And so those are hard things to study, but people are starting to really take note and pay more attention to those factors.
While we're getting the next question up here, on your tables is a table tent that has a QR code. If you are interested in research, please take a picture and fill out the questionnaire accordingly. It's right on your table if you're interested in participating in research. Our triage team will contact you, call you. Don't give us any information you're not going to respond to. This isn't a solicitation for funds, it's for your participation. So don't fill it out if you don't have any intention of answering the phone or answering the email.
She's tough.
Yeah, that's fine, I'll speak louder. Yeah, so my initial question was very similar to his. What are the environmental factors or habits that we can change to help this? But you answered that. Secondarily, what is the target number in terms of percentage in these studies where we can really start to get some answers, right? Because we've looked at it was 4 and then it's 17, but what is a good number where we can say, okay, now we can have some answers because we have a lot of data in these studies. Yeah.
So no, that's a really good question. And in fact, even though our numbers have grown, we still need larger numbers. So depending on what kind of work you're doing, what kind of question you're asking. So for example, if I want to divvy up the age-related rates of silent Alzheimer's pathology, even though the first pass that I took at that had, I think, about 200 something healthy African-American participants. But once I start splitting that up into age less than 55, 55 to 60, 60, and so then it starts to fall apart. And so you need larger numbers. There is no upper limit. As far as I'm concerned, we've done so much work and we're never gonna, we're not keeping white people out of our research, right? So, and there are lots of volunteers. We're not excluding anybody, but we have so much data and there's been so much research on certain populations. I don't think there's an upper limit. If we had 80% Black men, I'm fine with that. I'm fine with that. So, the higher the number goes, the better opportunities we have to do meaningful research.
Hello. My question is, I keep hearing about the markers with amyloid and tau proteins as being the markers that you find dementia. From coming here, correct me if I'm wrong, this data shows that African Americans have more tau protein than the amyloid, and the studies and the drugs that I hear about are about amyloid protein. So I know we're talking about a whole bunch of different other areas or scenarios why we are affected greater, but could there be a more necessity to look at why tau is so prevalent in us, and is that the marker that causes the progression of disease for African Americans?
Great question. You're a pro. You've been at a lot of events, haven't you? Although you got it backwards on the tau. So when we've looked, and I think I might have presented this at one point, maybe a year or so ago. But the levels, when we look at different populations, so if we just focus on people who we evaluate in clinic and we think they have Alzheimer's disease, right? So we make a clinical diagnosis of Alzheimer's disease. Maybe it's right, maybe it's not right. So I always think I'm right, but I was wrong that one time in 2006. But if we just compare people that we think have Alzheimer's disease and say among white individuals who are diagnosed with Alzheimer's disease and Black individuals who are diagnosed with Alzheimer's disease, how do those levels of amyloid and tau differ? The amyloid is about the same, but the levels of the tau protein in Black patients that we diagnose with Alzheimer's disease is 20 to 25% lower than in white patients diagnosed with Alzheimer's disease. And the same holds true for healthy people. So among healthy white people and healthy Black people, the levels of the tau protein in the spinal fluid is 20 to 25% lower among healthy Black people. I have no idea why that is. In healthy Black folks, the levels of the amyloid protein is also lower than what it is in healthy white people. So so why these differences exist, we don't know. But to know that they do exist is important, because otherwise you're going to wind up using the wrong numbers to diagnose people. You're going to misdiagnose people, or you're going to exclude people. Like, for example, we know that there's a blood test. In fact, the blood test that was used to screen and filter out a lot of people, that blood test result is also different between African Americans and non-Hispanic ones. But we use the same cutoff for everybody. And so we don't know why these differences occur, but we have to know that they do occur and that they are differences. As far as targeting different therapies, I think as opposed to, we've been spending so much time targeting amyloid. I'm sick to death of amyloid. Well, we are targeting now drugs to remove the tau pathology. We're also looking at drugs to attack inflammation in the brain and other contributors to Alzheimer's disease. But we need to expand that. So, rising tide lifts all boats, and the advances in Alzheimer's disease treatment is going to help everybody in advanced research and treatment in other areas. But we really need to focus on how to target, maybe it's Alzheimer's disease plus vascular changes that are much more common in African Americans than it is among non-Hispanic whites. We don't know. We need to figure that out. We need to know what the differences are. We need to study that, and then we need to target therapies appropriately. It's not one size fits all.
Good. My name is Lowton Morris, and I stand with a question about two sides. I'm a caregiver, and when I hear this and the drugs, and we've gotten several drugs from different folks, how do I get into that? I've been lucky enough that Dr. Parker got me upstairs with my spouse, my wife, and we're in an IMC about for her to be evaluated about around the drug thing. That's mine. I also stand as a veteran of Vietnam when I had no choice sometimes to be drafted. And I end up with a small amount of shrapnel in my lower legs. And I'm in the research program. And they stopped it. I'm still in it because of that, because they wouldn't go to MRI, and they didn't do the fluids. And, I've been through several MRI machines. Okay, and boom, everything just got out.
Yeah, you were in the MRI scanner, and that shrapnel didn't come flying out of there and hit nobody, nothing. Yeah, so I'll take that question first, because it's really annoying. But the research MRI scan. So when we do research, we're a lot more cautious. So if I do an MRI scan or a spinal tap as part of research, that's not important to you. That's important to me. It's not important to you. It might be important to you, but not in the same way. And so I may tolerate more risk if I'm doing a clinical MRI scan and I need to see what's going on in a brain or your stomach or in your chest or whatever, and I need to know that to take care of you, to take care of a medical issue. And so under those circumstances, we're going to be a little bit more tolerant of minor risk. I think the research MRI folks go a little overboard, and they won't do scans if there's even a tiny infinitesimal risk of something happening because of shrapnel from Vietnam. So that's why they exclude you. We can still do other research with you. In fact, we make lots of exceptions and say, well, that's stupid. They're not going to let him have an MRI scan. Well, we can do everything else. So we can do that. As far as the treatments are concerned, there's, I didn't go into a lot of details on this, but in addition to the risk the gentleman asked about, these treatments, removing the amyloid, we can remove the amyloid at any stage of disease. But what we've known for a long time now is if you don't get to that pathology, removing the amyloid, you don't get to it soon enough, it doesn't help. And so it exposes you to all the risk and treatment issues, and it doesn't slow down the progression. And that makes sense if you think about it. In fact, a lot of us, I think, were skeptical that removing amyloid was ever going to have a clinical impact, because I showed you that slide where that pathology is building up for 15 to 20 years. And so, and the first pathology that we think is building up in Alzheimer's disease is amyloid. And so if it's been building up for 10, 15, 20 years, and then you go and remove it after the fact, it's still triggered all the other things that are going wrong in the brain. So it doesn't do you any good to remove that amyloid unless you get to it early enough. And that's why I think the prevention using anti-amyloid treatment is going to be more effective, but we just aren't there yet. And we need to develop better drugs for people who are already sick. But that's a much tougher hill to climb. You know, it's like I gotta go do my stupid colonoscopy. I've still been putting it off. But you do that because if you get that colon cancer when it's just a little polyp, you're okay. But if you get that colon cancer after it's metastasized, you're going to be in trouble. And so that's really what we're dealing with a progressive disease like Alzheimer's. And so it makes a big difference where the person is in their journey, whether these newer treatments are effective. And for people who are beyond a certain age, at a certain stage, they're not, unfortunately.
Last question right here.
Yeah, Dr. Lau, thank you for your presentation. I had two quick questions, one of which you touched on. One is that, is there any regional distribution of Alzheimer's disease in the United States? And my second question is, once treatment has been initiated for Alzheimer's disease, is that a lifelong treatment that's necessary?
Both really outstanding questions. And some of the interpretation of the geographic distribution is a little tricky because the single biggest risk factor for Alzheimer's or any other type of dementia is age. And so depending on the age demographic in different regions of the country, the rates of Alzheimer's and dementias may be higher. But there is also, you may be aware, there is something that we refer to as the stroke belt that kind of goes through the lower Midwest and through the southeast. And that is a region of the country that has a much higher risk of cerebrovascular disease and stroke. And I don't know the numbers on this as well as I do with dementia and Alzheimer's, but it's much higher among African Americans. And so I think there is partly a geographical distribution that mirrors the stroke risk geographically in this country. As far as the treatments are concerned, one of the companies that developed the one drug, Leqembi, that the standard treatment for it is 18 months while you try and remove that amyloid. And so one of the questions is, well, what do you do after you've removed the amyloid? If the treatment target is that amyloid and it's all gone, what should you do? And you never guess what the company said. Keep giving it. Keep giving it forever. Because it'll be really good for our bottom line. We think that there's going to have to be some type of maintenance therapy, but the rationale for this, the logic of this is we know what these drugs are designed to do. They're designed to go in there and clear out that amyloid. And so once that amyloid is all gone, what should you do? We think some maintenance is required because this stuff is always building up. This amyloid protein is being made in every one of our brains right now. Why it accumulates in some brains and not in others, we don't really know. But somebody who's had that process and they're still making, we think some maintenance therapy is going to be needed. We don't know what. But I'm hoping that what happens is over the next several years, we get through using these amyloid treatments, and then we add on maybe a tau treatment or a neuroinflammation treatment. Something, this is like I said, the first step. It's a really important first step, but it ain't the last step. we got to keep pushing this and trying to improve our treatments, and then switch our way to doing earlier detection and prevention, and not waiting till people get sick. So thank you very much. And Dr. Parker says we're winding down now, right?